AI replace clinical judgment? So I want to start out with this question. We have a very quick case study to drive home the point with some final thoughts on this clinical judgment and CDI can I replace. So AI, here's the point, folks. AI can identify documentation gaps, suggest diagnosis, and even recommend physician queries. Can an algorithm truly evaluate medical necessity, clinical reasoning, and the patient's story, with emphasis on the patient's story now? The way an experienced CDI specialist, physician advisor, or clinician can. Where should healthcare organizations, here's the key point here. Where should healthcare organizations draw the line between AI assistance and human clinical expertise? Shalivia, I know we had a heated discussion last Thursday night at midnight my time, because I think you were in Hawaii. So I want your thoughts on a couple of ideas here. AI as an augmentation tool versus a replacement for CDI professionals. Is it being treated as an augmentation tool, or are you seeing a replacement for CDI professionals?
It all boils down to one word, and that's governance. So if your AI tool is configured for revenue enhancement, that's what it's going to go for. If your AI tool is geared towards getting to the clinical truth, then that's the right way to go.
And I agree. Really, if you think about AI, it should be an augmentation tool. But I'm seeing way too many instances of queries being generated. CDI is thinking, oh, it's AI. It must be right. It must be correct. And Shalivia, you're shaking your head like you agree. What are you seeing in your facility where you're consulting?
I, for us in the facility I'm consulting, AI is an accelerator. It definitely is not a replacement for clinical judgment. It can review records very quickly.
That's right.
You know, it can identify opportunities in line with the guardrails that has been set in place, right? As Dr. Limhoko said, that governance component is a key component to AI in our space. For example, I'm working with my team at the organization I'm consulting with, and we wanted to turn on 3 nudges is what we call it. I talked to the medical director for the hospitalist team and I asked him, I was like, help me understand areas of opportunity where we can turn on some clinical reasoning behind the scenes to nudge you for certain concepts you feel like it's just straightforward. So we decided on 3: hyponatremia, hypernatremia, and CKD.
Oh,
What
that's
we
great.
found out, though, what we
Yeah?
found out with the CKD, it could not read the chart because of the actual application. It could not read the patient's history. So it was
Really? No,
erroneously,
no kidding.
it couldn't read the patient's story. So it's an
Unbelievable.
accelerator. So
Yeah?
for the electrolyte imbalances, that accelerator helped. It helped a lot because it actually reviewed the lab results and it was able to give them the results in a matter of seconds, right when they were completing their note. So for that particular nudge, we thought that it was helpful in accelerating the process and bringing things to the forefront very quickly. For the AKI nudge, not so much because
Yeah?
it couldn't read the patient's history. It couldn't see that the patient did not have a history of CKD. It couldn't
Yeah?
see the patient had AKI, and that's
Oh,
why the
no.
GFRs were abnormal. It had nothing to do with CKD in itself. So of course we're going to turn that nudge off. So to all of you guys' points, governance was key here. We recognize it was an accelerator and it could not identify clinical judgment. It cannot replace clinical judgment. It can only accelerate, assist the physician in reviewing a lot of key components quickly. So I think that's the key here. It is not, it doesn't replace clinical judgment, but it can accelerate.
Oh, that's
Can I
music to
add
my ear.
something here,
Yeah,
Glenn?
go ahead,
Can I
Lemhoko.
add something?
Dr. Lemhoko.
Here's the thing. Right now, we are in the evolution of AI. So
Mhm.
it's kind of crude at this point, and as what Shalivia was describing, it's very limited. But
Mhm.
just think about this. That I want to put this into perspective. Just think about when it
Mhm.
hits the level of AGI, which is the what do you call AGI? Something general,
The agentic AI
no, the
component.
average general intelligence, and even up beyond that is the super intelligence.
Mhm.
Right?
Think about this. If you can feed the AI all of the peer-reviewed medical
Uh,
literature
Like open
from
it, like
from the
like open
beginning,
evidence.
right?
yeah.
And bring it, and every time there's a new thing, it comes there, okay? If an AI is fed that, okay, and is able to learn that and it's given the right guardrails, the right governance,
Mhm.
don't you think that it will be able to outdo what a physician can actually do? Because as a physician, I am not able to recall all of the things that I've actually learned or
Right.
read
It's a
from.
tool. It's a
It's a
tool. It's a
tool, okay.
rule. It's a
But but
resource.
but think about it. When it gets to that level of super AI and it's able to actually use all of the data, all of the information, all of the things that we learned as physicians in right there before it, it will be able to actually do better than the human doctor because the human doctor is limited. We can only have so much information in our
And
head.
considering that most physicians use up to date, they need some type of resource to be up to date in management because medicine's evolving. And this brings me to my next question. Okay, here we go. If AI cannot explain, okay, this speaks to you, Shalivia. Okay,
Mhm.
your comment earlier. If AI can't explain the patient's clinical story, defend medical necessity, or exercise physician judgment, we know that it can't. It's not capable of doing all those. Specifically, clinical judgment and medical necessity.
Mhm.
Is AI transforming CDI or simply making CDI 101's processes faster? Or is it really cementing the continuation of reactive transactional repetitive queries? That's my question.
I think it depends on who's leading the way, honestly. And I think what Dr. Lim Hoko was saying also speaks into this question. It's definitely an accelerator. It can reason over things very, very quickly. And when we get to that next level, if it could bring in all the evidence-based, peer-reviewed articles up to date, it's still an accelerator. It doesn't replace the human being clinical reason or the provider's clinical reasoning.
Yeah,
So I think what we're losing sight of, or the way we're using it today, we're staying in that standard status quo practice because
that's
we're
right.
not elevating it to the next level through
That's
that
right.
governance practice. Because if I go through all of the governance steps I took to actually get to the point where I'm going to implement two nudges on August 17th, we've been going through, we turned it on, we looked at the guardrails behind the scenes, we reevaluated it, we tried to hone in on the guardrails, aka rules, that was put in place to allow the AI engine to work.
Hmm.
We tested it, we vetted it, we turned it on in silent mode. Like we went through a full governance process to actually get to the step of implementing. I don't know if all health systems are doing that to push forward to 2.0. We get the software. It seems like right now the software is given to us. We let the vendor dictate how we roll it out, and we don't take the time to truly understand what we're rolling out.
Well, here's the other thing I wanted to going forward, going to the future. So let me step back one bit, and that is I just wrote an article on dehydration versus sepsis, and you can see that both hypovolemia and sepsis have overlapping symptoms. The arc of the disease processes and how when you monitor how it evolves, that's when the clinical truth comes out.
Mm-hmm,
But
mm-hmm,
the way we're as an industry right now, the way we're looking at it is static. It's not dynamic.
Yes.
We have to look at the arc of the disease process. As as a static process, CDI is only going to see one screenshot of the whole process. It will jump into conclusion that the patient has this condition. But the real clinical judgment stems from looking at the full arc of the disease. By the way, let me just go forward about that. At that point that we have super intelligence, where we can actually plug the patient directly to the machine
Mm-hmm.
by whatever way. And the machine can then monitor the arc of the disease process. The machine, the AI, may be able to even out the knowledge, the skills of the physicians at that point.
Here's a situation. Real case. I was asked to review, okay, by the individual who reviews records to see whether observation could be upgraded to inpatient, and is there opportunity for documentation enhancement in a clinical truth way, Dr. Lemhogo, okay? So here's the situation. This is a 75-year-old woman. She was admitted with weakness and lethargy. She had abdominal pain. She had UTI. She was just discharged about a week ago with UTI. She said she was compliant with her meds, but she still had flank pain and dysuria. Okay, so they brought the patient in. Good. Okay, she said she was weak and not feeling herself. Okay, her urine was not sterile. And the doctor said the patient was weak and lethargic due to acute renal failure, likely secondary dehydration. Well, I like that. Cause and effect, that's important, right? Diagnosis, evidence, severity, cause and effect, treatment, and monitoring. That's the standard of documentation. Okay. There was okay. Oh, by the way, the doctor said Mrs. So and so is poor, unfortunate 75-year-old with a past medical history of metastatic colon cancer, hypertension, hyperlipidemia. Let's see what else he said. Okay. Presented and it had a sufficient HPI. No problems. Okay. That's the most important for medical necessity, right? HPI. Patient story, severity of illness, one of the four complex medical factors for Two-Midnight. Okay. Then the doctor says in his constitutional physical exam, alerting times 3, chronically ill appearing. Well, that's a subjective term. What do you mean? Are they frail? Are they cachectic? Do they look uncomfortable? Do they have? And then he said, remember dehydration. Okay, there was no clinical evidence of dehydration. Maybe clinical indicators, right? But clinical indicators support a diagnosis, but they don't establish it. The doctor does through the story and the documentation of the physical exam. Okay, no sunken eyes, no poor skin turgor, no dry mouth, nothing. Okay. And then acute renal failure, he didn't use the KDIGO criteria. Okay. He didn't say the baseline creatinine. He didn't say what it was today, what it was last time, 7 days ago when they were discharged, right? They didn't give us that information. So what's going to happen to that acute renal failure? It's going to be denied for clinical validation. Rightfully so. I can't say the payer is egregious in this situation. Then you said dehydration. Nice. I like that. The way he said cause and effect. No clinical evidence, no clinical labs mentioned. He didn't even give us the amount of fluid that the patient was going to receive. It's a 75 cc's, that's maintenance. Is it 125? Well, that doesn't sound too much like dehydration clinically from a clinical judgment standpoint. But if they had heart failure, you may say, I don't want to overwhelm the patient. Okay, here's what they missed. The BMI was 18. The lady is 5'6". She weighs 98 pounds. Okay. Well, you can imagine that patient now, right?
Mm-hmm.
Okay. Was she cachectic? Likely so. That wasn't in the chart. No BMI. no discussion of is the patient losing weight unintentionally. There was no discussion of whether the patient is active on the chemotherapy or radiation. So we got a history of, okay. We have metastatic, but we don't know where, right? Where was it from? And we don't have acute renal failure. So if the payer takes away acute renal failure, what do we have left?
Nada.
Nothing. No, weakness and lethargy. And UTI, because they were in the hospital, they hung a bag. Okay. But they could have been done in the ED treatment street. But they're okay. Wait a minute. This is even better. Then we'll have your closing remarks. This is a real juicy case, okay, of why AI, the CDI needs to read the record, right? They needs to read the chart and the context. Okay. In the ED, the doctor said concern for MI because they had an elevated troponin. One. Okay, one. Dr. Limhoko is smiling. Okay, one lab. So what do you think the software flagged this case for? Is this a type 2 MI, demand ischemia, chronic ischemia, or unable to determine other choice? Okay. We haven't even solidified the principal diagnosis, and we missed all the opportunities to solidify as an inpatient. So this was downgraded to observation. And I agree. There's no reason for inpatient admission in this patient, right? All we have is an abnormal lab value with supposed dehydration. That's a treat and street, or that's observation at the most. Okay, could it be inpatient? Absolutely. Do you agree? What are your thoughts in closing here?
If it were properly documented with the cachexia and
Yep.
malnutrition and the weight loss and all of that.
Oh, wait, I forgot something. The patient was put on Medgase too.
Okay, malnutrition for sure.
Yeah, okay, because what's
Malnutrition.
that for? AIDS, HIV, cancer related, not
Usually,
eating.
yes, usually
Okay, so this
nutrition.
patient is actively an active cancer patient. Okay,
Yeah.
obviously I can't guarantee it, but it sure sounds like it. So we missed all these opportunities, and the AI didn't even mention any of these things. It just mentioned, "Hey, go try to get the MCC of an MI." I mean, I was almost like cussing. I said, "This is unbelievable." Right?
No, you, Glenn, you don't cuss.
Oh, I do when I'm not on Zoom, when I see a case like this. Okay, so let me close with this. Okay, I want to get a closing remarks. Okay, uh, what should I think this is a great closing question for you all. What hospital executives should what should hospital executives realistically expect from Aon investment in CDI? Because I want to just throw this sentence in there. I firmly believe that they're being misled in the sales process to say, buy this software, deploy it, you'll get instant return on investment of X number of dollars, 5-to-1. I saw one 5-to-1 return on investment with X million dollars per 10,000 discharges. That resonates with CFOs. They're looking for money, and I don't blame them. They have to get paid. But it's opened up a lot of compliance concerns. Your thoughts, Shalaria? I know you're seeing this in the industry. What are your thoughts?
I think you made a great point in the example you provided that artificial intelligence recognize patterns in line with guardrails and rules that have been put in place and programmed to work. And in that particular example you provided, likely it may have not had a nudge or an AI prompt
Or algorithm?
designed to recognize that the patient was probably malnourished and it may have something to do with their malignancy that they may or may not have, right? That's why clinical judgment is needed, right?
That's right.
So the
Any
future, I'm sorry, I was just going to close with the future isn't about replacing clinicians with AI. It's
no,
empowering them. And how can they work
it's a
together?
tool. It's a
It's a tool.
resource.
Yes.
But I think. Well, never mind. Let me let Dr. Limho go. Closing
Oh, I think
remarks. What are your
I
thoughts?
agree. I agree. The AI that we have right now is still at its crude level. We don't know how far it's going to go, but nevertheless, the guardrails, governance is key. Even
Mhm.
without the AI, even with any tool out there, it is
Mhm.
key that governance is the number one thing that should be dominating our mindsets, our conversations, and our policies. Um,
And I want to add just very quickly in closing, and a great points, Dr. Limhoko, is that is that uh, as AI evolves, right? As AI evolves, remember you said evolution, okay? As it evolves, uh, we have to evolve as a profession. Just,
Mhm.
and I know I've been talking all about CDI 2.0, and Dr. Limhoko, you were saying, do I dream this? Last night I did have a dream about CDI 2.0, to be honest with you, at 2:37 in the morning,
was it a good
okay?
one? Was it a good one,
Yeah,
Glenn?
oh yeah. I mean, I was it to me to come up with a post on LinkedIn. Okay, so the situation is I want to close by saying, uh, that this is the time for us to not consider. We must embrace CDI 2.0 to complement and AI, serve as a resource to the doctors, facilitators, enablers, up our skill set to understanding the medical record as a communication tool, being able to identify true insufficiencies or true opportunities that AI does not identify, or where can I solidify the medical necessity, as opposed to saying, let me open up the chart and see what diagnosis I can query for. So we have to change. I want to thank you all. This has been wonderful. And let's keep the discussion going, Dr. Limhoko. Love your post on LinkedIn. If you haven't followed Tralivia, she posts now and then. Uh, Wonderful. I comment on them and stir up the pot, if you will, which I like to do in a professional way. Dr. Limhoko, keep up the post. And if you haven't followed all of us on LinkedIn, please do. We're not out there to advertise. We're there to provoke discussion on where we need to go as a profession. We have to change. Change is inevitable. Change is not something people like, but if we don't, we're going to go the way of the dinosaur. Okay. Thank you very much. Keep up the great work. Don't give up hope. Okay.
Mission versus margins.
Appreciate it. You take it easy. Have a great day, everyone. Bye bye.
Bye.
Bye.